I would like to go ahead and welcome our panelists. And so we have three world's experts. First, we have Ed Wu, who's the director of the vascular program at MedStar and the chairman of the Department of Vascular Surgery and professor of surgery at Georgetown. Second, we have Jason Lee, who is a great Warriors fan. Despite that, I really like him. He's a director of endovascular surgery and a professor of surgery at Stanford. And then last but not least, Darren Schneider, who is the chief at Cornell and soon to be within the next month, starting July 1st at University of Pennsylvania. So we're going to have some great cases. We're going to kick it off with Ed, who's going to talk to us about up in the thoracic aorta. So why don't we go ahead and bring up Dr. Wu's slides and get started with our first case.
There we go. Is that okay?
Great.
Yes.
Great. Thanks, Sean. Thanks, Saher. So I'm going to start today with a case of a Type B dissection with chronic aneurysmal degeneration. It's an interesting story and certainly a fair amount of debate in terms of how to treat this type of pathology. Frozen. There we go. So we have a 53-year-old female, chronic Type B dissection. She presented with progressive enlargement of the false lumen at the distal arch, which is typically where you'll see this. And here's a M2S representation. You can obviously see the yellow is thrombus. You can see the pink and red are demonstrative of true and false lumen. And you can see again where typically it enlarges in that distal arch area. And there's the true lumen. You can see somewhat compressed, false lumen coming back. And again, aneurysmal degeneration with enlargement in that area. And just running through the axial images here, you can see it from this perspective. Big false lumen there, partially thrombosed at the arch, but then you can see that it refills again, small compressed true lumen. And then the aorta somewhat normalizes as you get down to that mid to distal descending thoracic aorta. You can see as we run down into the abdominal component that false lumen is still perfused. You can see the contrast is run out a little bit later here and eventually just kind of disappears, and down by the infrarenal aorta, it normalizes. So that's our first question. What is the best plan of treatment? Open repair with distal aortic perfusion, observation, TVAR landing distal to the left subclavian artery, TVAR landing proximal to the left subclavian artery, or explantation of the entire aorta.
So everybody will have that poll question come up on their computer, and if everybody wants to go ahead and vote. I think this is an area of huge controversy. I mean, I know in my last 20 years, my practice has continued to change, and I think some of it depends to me on how likely I am to pick things off or how likely I am to create malperfusion distally. I don't know if maybe Darren or Jason or Saher want to comment of like what you guys like to do here.
Yeah, I think this is a challenge, and I think it's also an interesting case. The patient's relatively young too, so you know, if there's a genetic connective tissue disease attached to this, then that definitely changes the answer and would make me lean more towards open surgery. But if that's not the case, then I do think that endovascular options are on the table.
I think the other tough thing is related to the fact that now that it's chronic, then clearly persistent false lumen expansion would be typically the main reason to intervene. And just based on the imaging, Ed, the distal landing zone's going to require some creativity to get a seal distally, I think.
So what would you do, Ed? Enlighten us on how you treated this. We can see that most of the people in the poll had felt that TVAR proximal to the left subclavian artery.
And I'm happy to see that nobody chose explantation of the aorta. It was a trick question.
I almost did, yeah.
Frozen again. There we go. So we chose to do TVAR distal to the, proximal to the left subclavian artery. And we decided to use the Gore TBE device on clinical trial. You can see here we have the device in place. You can see it's proximal. and then with a wire access from the groin through the radial artery to cannulate that the branch of the TBE. And this is just a still image of what I was describing here. You can see the innominate artery, the left common. You can see the markers abutting the orifice of the left common carotid artery. Again, that wire with a catheter through that left subclavian artery. We typically use radial access for this so that, you can just, it's very simple. You don't have to access the brachial. And then you can see that port or the branch extending right at that left subclavian artery. And that's our intent there in terms of preserving that left subclavian artery. And this is just a still image, or you can see it's all deployed. The device is deployed, as you can see. You can see the branch, and you can see the branch extending into that left subclavian artery. Obviously, you want to be careful to preserve your vertebral artery and NEMA when at all possible, because that's part of the reason you're doing this in the first place. But again, you can see that nice image with the extension into that left subclavian. Which brings us to our second poll question. What is the significance of left subclavian artery revascularization? None, always revascularize, revascularize selectively, flip a coin to determine.
So while we're waiting for people to vote, maybe we can have our panelists sort of chime in. I would say that at the clinic, some of my partners are always, I sit more on a selective, but I would tell you that over the last 15 years, there becomes less and less reasons not selecting to revascularize the subclavian. I'm sort of now emergently, I'd rather not, but electively, I almost always do. How about the rest of the group?
Yeah, I would agree. I mean, I think that for elective cases, we virtually always revascularize the left subclavian artery. I think if you're dealing with an emergent situation with a complicated acute type B dissection or somebody with a aortic disruption, those are cases when you just cover it because you just got to get the patient out of trouble. But otherwise, elective cases, I revascularize.
Yeah, very, very similar approach. I don't think that you should that you can walk away from revascularizing it when suddenly out of the emergent scenario, particularly if there's some complication or even some mild sort of neurovascular or neurologic compromise, and I think you just do it.
So before we go on, what do our experts do when you're that 3 or 4% of patients that has that left vertebra coming off the arch, and it's a case like Ed's here where you really want to cover the left subclavian to get the graft in a nice parallel, stable landing zone?
We'll typically reimplant that vert. You do the carotid subclavian bypass, and then when you just go posterior to that common carotid artery, it's pretty simple to find that vert. Just you can transect it, bring it up, and do an end to side to the common carotid artery. And we've had good results doing that. But I think you have to preserve it. I think you have to preserve it, obviously, for the brain. And then it's also a pretty important collateral for the left subclavian artery. So I think for both the arm and the brain, it's important to keep it.
Yeah,
we do the same, and it is fairly straightforward to do that. I think the exception again is going to be the urgent case, and when I do that, I usually do angiography looking at the contralateral vert to make sure that there's not anomalous anatomy and that anomalous vert is not the dominant vert before I cover it.
It's interesting, probably about 10 years ago when, maybe even a little bit earlier, when we really started getting aggressive with the T-bars, a lot of controversy, right? I mean, lots and lots of papers written about left subclavian artery revascularization, whether it was necessary or not. And I think that for the most part, as you and everybody else has said on the panel, we've moved towards revascularizing pretty much everyone on an elective basis when we can.
For the patients that are not revascularized, how often do you feel like you need to go back because of arm claudication and other symptoms? I know we looked at our data when I was at UVA, and we had around 20% of the patients need to come back for arm claudication, the one that were, just not revascularized because of emergency or because it was a short segment and used a selective method. So what's your experience been to revascularize after the fact?
I think that happens with some frequency, like you said. That feels about right, 20%. Particularly many of these patients, particularly the dissection population that's done urgently where we would have covered and seen how they do, they tend to be younger. and want to use their left arm still. I think if it's an older, much older patient, chronic aneurysm, or even a rupture or something that you're doing urgently, you may or may not see them back for left subclavian revasc. But a young person, definitely, you wind up seeing that back later when they're recovered from their aortic, emergency.
And I'd agree. I think the other thing is that if it's a dissection, you're likely to have false lumen feed of the channel from that left subclavian, and so you're going to be dealing with it more from that standpoint than arm ischemia. I mean, I'd say it's probably 10%. It's been my experience with really arm ischemia, and most of the time it looks really bad for 24 hours, but by the couple of days later, it's pretty good.
So clearly, we thought that was important, and that's why we chose to do the TBE. And you can see here, this is kind of the extent of the device. So extending from the, again, left common carotid artery, the TBE, and then a second tag device to overlap. And you can see the impingement kind of in that mid-thoracic aorta where that true lumen was compressed. And again, you saw that on both the axials and the M2S reconstructions when I took off that false lumen. And so the real question here, as Jason alluded to earlier, is what do we do in terms of managing this false lumen to get a durable result? So the next poll question and final one is, does the false lumen management matter? Yes, no, what's the false lumen?
And here's the best, is I think we'll probably get all of us to disagree. I think over time I've changed, and I'm not sure I know the right answer, but I know if you can get it to thrombose and propagate, it's great. And when it doesn't, it's one of those nemesis that comes back to bug you for a long time. And I'm not sure how you make that happen other than covering every channel. And so maybe we can say that, who's going to cover to the celiac every time, and then who's going to try and do something with that lumen. So how about our panelists?
I'll start. I actually do both. I bring it to the celiac or close to it, and then I'm going to do something with the false lumen whenever I can. Because the main concern, and I see there's a 5%, what's the false lumen, and that's probably a question of what's the false lumen concern. And just to answer that, what happens is, if you remember running down the axials, you see the kind of double barrel appearance. And so what we're concerned about is that TVAR is extending only in that true lumen, and we've treated any fenestrations within the thoracic aorta and obviously the primary entry tear. But what can happen is the fenestrations down distal to the TVAR can continue to feed the false lumen, and that blood flow can go retrograde back up into the thoracic aorta, back into that distal arch segment. And so you end up not potentially treating the patient as it's still pressurized. And so that's the argument of why to treat the false lumen. So I do that, and I bring it as far down as I can, and then I'll also try to treat the false lumen. We can debate, and talk about how treatment plans after everyone else responds.
We'll actually stage it quite a bit, and so I agree with Ed to bring it down to the celiac, and then often we'll stop and then get some imaging and see how much the retrograde flow goes back up, and if then the false lumen aneurysmal enlargement slows down, or if you think the patient's reliable to follow up, you might have, then I think you might be done. If it still persists, then that's a secondary procedure of all the false lumen closure strategies that are out there. But I try not to do it all in one setting. There's probably some spinal cord safety by not 100% obliterating the false lumen.
I agree with Jason. I mean, I think that we all know that in the long term, TVAR for a chronic dissection is going to fail unless you stop false lumen flow. I think that we can all agree on that now. And I think the debate is going to be how to do that and the timing of that. For this case, it's an elective case. It's also on a trial protocol, so I'm not sure what you're allowed to do in the trial. But I would cover down to the celiac. I probably wouldn't do additional embolization maneuvers within the false lumen. I'd do the subsequent imaging and then plan to come back. I think when you talk to these patients, you got to tell them that sometimes this is a project and it's a stage approach to this, and it's not just a single procedure necessarily. This is not a straightforward problem.
At the end of the procedure, like when you do your angiogram and you see the fast filling of the false lumen through a big fenestration that goes all the way up to your, the just below the subclavian. Would that affect your decision to go ahead and you do something, or you always would leave it? I know Jason and Darren said you would most likely stage it, but if you see like, you know, uproaring filling all the way up, would you be more compelled to do something?
No, I definitely would. And there are circumstances where there's a dissection involving the left subclavian with a false lumen in the left subclavian, and you can have, you know, brisk outflow via that left subclavian false lumen. I think in that circumstance, I'd chase that and try to close that off. But I'm not sure that I would, you know, pursue candy plugs and coils and trying to immediately thrombose the entire false lumen in one fell swoop.
So to keep us on time, Ed, let's talk about what you did after this.
So what we did was what's called a Knickerbocker technique. And so we basically expand or balloon out that T-bar to basically appose that chronic flap against the total aortic wall to close off that false lumen. And you can see what happens with that. You take a balloon and you go until it pops, and it's a little scary. And again, you can see what it looks like here. It was really thin, obviously, in that mid-thoracic segment before, but here it's now it's totally expanded to meet the diameter of the entire thoracic aorta. And you can see here what our completion looks like. You can see nice flow down that T-bar, and obviously no retrograde flow back up past that segment of where it's expanded, where the Knickerbocker is performed.
But there's two really key points. One, you stayed away from the end of this device and you didn't go up proximally, because I think all of us early in our learning curves did it down distally and created a new anterior distally, and we've all done it proximally and created a retrograde type A.
Yep.
Yeah, that's a real nice demonstration of that technique. We found that if you find that area right around the diaphragm, sometimes it's right in the oxbow, where it's the total true plus false lumen is smaller than the actual diameter of the aorta, and you make sure you leave a couple centimeters. It looks like 5 centimeters there. You kept alone. I think it's a real nice way to stop the retrograde flow. It looks real pretty there. Ed.
Let me just show you.
Yeah, no, it looks great. I think the other thing is really avoiding that proximal dilation, because not only can you create the retrograde type A, but you could cause the entire proximal end of that device to migrate, and you've got that subclavian branch that could be a disaster. One question for you, Ed. You know, when you size these for a chronic dissection, you know, how are you sizing your endograft? I know in this case you're probably sizing it adequately, so with the Knickerbocker you could get to the true diameter of the aorta in that location. But did you go beyond that, oversizing beyond that?
Just by a little bit. And so that's a great point. I think if you have like a 47 or 46 or 48, you know, total aortic diameter and its minimal component, I think the Knickerbocker is not going to work. I mean, you could try it, but it's probably not going to work, but you probably need to supplement it with some type of embolization technique like we talked about. So let me just run this through again, sorry. And so you can see the stent into the subclavian. You can see this is, I think, 2 years out. Her aneurysm is completely underground. No flow.
Totally shrunken down. That's perfect.
Amazing, right? I mean, when you take that out, you take out the pressure, it treats it, and that's really that's what you need to do. And Darren, you know, you said this earlier. It's you know, if you don't manage that false lumen, you're going to come back and it's going to bite you at some point for sure. So, well, thank you.